Welcome to DEBAKEY Live. Today is Heart Failure Hour, and for the Heart Failure Hour, we'll be doing a journal scan, where we will be reviewing 4 articles within this hour, and all the 4 articles will be relevant to heart transplantation, and we'll use these articles really as a segue into a conversation about controversies and challenges in heart transplantation today. So I'm Dr. Ashrith Guha, one of the heart failure transplant cardiologists here at the Methodist DEBAKEY Heart and Vascular Center. And joining me today is Dr. Thomas McIlvery, who is our Chief Surgeon and Director of Thoracic Transplant and Chief of Cardiac Surgery. And we have Dr. Arvind Bhimaraj, who is our interim division director for the heart failure division and also the medical director for heart transplant and mechanical circulatory support. And we have Dr. Barry Trachtenberg, who is our director of the Amyloid program as well as our Cardio-Oncology program. And to present our 4 articles today, we have our Heart Failure Fellows, Dr. Miguel Castro and Anusha Sunkara. So why don't we get started? We'll get started with Dr. Castro presenting 2 articles.
And everyone see my slides? Yes? Okay. So good afternoon, everyone. I am Dr. Miguel Castro. I'm going to be talking about 2 of the papers. So the first paper I'm going to talk about is, the title is Challenges in Heart Transplantation During COVID-19, a Single Center Experience. So this study was actually published earlier this year, coming out of Mount Sinai, with actually one of our alumni, Dr. Aditi Singhvi, being the lead author on this study. So first, the background on this this article. So as we all know, COVID-19 has been the bane of our existence for the past 6+ months, and affecting millions of people and also taking the lives of thousands of people. And despite it being a relatively new disease, we have kind of a good grasp of how it affects the general populations, but in the heart transplant world and in the patients awaiting heart transplant, it's not as well described, its manifestations and outcomes. And the reason it's important to know about this is because these patients can be affected and be vulnerable for several reasons. First, these patients are immunosuppressed, which may render them more susceptible to acquiring COVID-19 and developing severe disease. There's also an argument that these patients can actually be protected by the immunosuppression, which may mitigate the immune response that these patients develop that have COVID-19. And another issue affecting these patients is that the delivery of care, patients awaiting heart transplant may be affected due to limited healthcare resources during this pandemic, and also restriction in organ transplantation, which can lead to higher waitlist mortality. So that's the background on this study. So the objective of this study was to describe the landscape of heart transplant care during the COVID-19 pandemic, recognize varied presentations in transplant patients with COVID-19, report the outcomes in this single center experience, and then highlight some clinical dilemmas encountered in their management, including experience in 5 transplants performed during the peak of the pandemic. So for the study design, this was a retrospective chart review of consecutive heart transplant patients with COVID-19 and waitlisted patients.
Well, we are having some trouble with Dr. Castro's internet, so I think we'll give him a couple of minutes. If he can't join in, I will
Yeah,
I'll take over the presentation.
Yeah, we can probably project his slides. That way he can. Yeah, I think while Dr. Guha is pulling up his slides, I think it's relevant to acknowledge the discussions that'll follow, and we can probably start with that as Ash, you're pulling up your slides to review the article. I think it's been quite a bit of a challenge in balancing the needs of transplanting individuals in a pandemic situation with this lethal virus that we've had. And what the study ends up showing, and also in our experience, the question becomes, are you going to transplant individuals, immunosuppress them, and take a chance on transplanting? So a few of our challenges that we had faced was really early on to make a decision on what do you do in these end-stage patients who need to be transplanted. Do we keep them stable with a balloon pump or an inotrope and not take the chance of immunosuppression? So in case they get COVID, they might succumb to it. Or is the alternative risk of COVID outcome, is that not as high as the risk of succumbing to heart failure when you're waiting for a transplant? I think those paradigms become quite challenging, and in this study, and maybe in our experience also, the outcomes of solid organ transplant individuals in general has been a mortality up to 20-23%, which is not trivial. But at the same time, somebody who's listed on the transplant list at a higher status, you're looking at a mortality rate which could be close to 50-60%. So we had made a choice that individuals who are in the hospital requiring support for the heart, we were justified in transplanting those individuals so that their risk benefit is justified. So and Ash, you've taken care of some of these patients with risk of COVID, and some of them have contracted it, right? And maybe you can share some of your thoughts on.
No, I think I was able to get the presentation up and going. So let's just review this paper really quick, and then we can get, I'll share my thoughts, as well as we can get Dr. McGilvray and Dr. Trachtenberg. So they described about 22 patients who had COVID, and the transplant program follows about 400 plus patients with heart transplantation, out of which.
But in the study institution,
they have who had contracted COVID, and these are some of the comorbidities that you all can see here with hypertension, diabetes in a vast majority of them, and lung disease in about 13% of them, and 13% of them on dialysis as well. In terms of the presentation, again, a lot of these patients really did not have much of a fever, and I think Miguel got his slides back, so we'll transition back to him.
We left off here, I believe. So again, just showing the clinical characteristics. Not many of these patients had fever. Only two of these patients developed hypotension. All of the patients had lymphopenia with an absolute lymphocyte count median of 0.6. Most of the patients had kidney dysfunction and elevated D-dimer and troponin. Of the patients that had developed elevated troponin, none of them developed LV dysfunction that was reported. And of the patients that had cardiac allograft vasculopathy, none of them, actually only one of them developed elevated troponin. And 35% of the patients developed multifocal opacities on imaging. In terms of management and outcomes, like as I mentioned before, 19 patients were hospitalized. 60 patients were hospitalized at the study institution and 3 at outside hospitals. None of the patients required ECMO, and their calcineurin inhibitor trough was not modified during treatment. Mortality was reported at 22%, And all 3 of the patients admitted to outside hospitals ultimately required intubation and ultimately expired. When looking at the management, supplemental oxygen use was used in 63% of patients, with nasal cannula and mechanical ventilation being 26 and 21% respectively. Medication-wise, 55% of these patients did get hydroxychloroquine. Again, this was early in the pandemic, and azithromycin. 25% got high-dose glucocorticoids, and 55% received anticoagulation. And a good amount of patients did have their immunosuppression modified, just not their calcineurin inhibitors. So the antimetabolite was reduced or held in 61 and 23%. Respectively, and mTOR inhibitor was also reduced or held in 33 and 66% respectively. Again, the overall survival was 77%. The survival in hospitalized patients was 74%, and this is in the entire cohort. But the survival in patients that required ICU admission was actually 0. None of these patients survived. When looking at the study institution specifically, similar but a little bit better. The survival was 87%, and then again the survival in patients requiring ICU admission was 0. And then quickly, just looking at this table, this is just to point out that although this is a small sample size, there was no statistically significant factors that differentiated patients that were alive or dead, but they did mention that there was a trend towards significance and patients that had low lymphocyte count, high creatinine, a high D-dimer, and a high ferritin, but again, not significant. And then looking at the outcomes in patients that had transplantation during the COVID-19 pandemic, there were only 5 patients during this time. Median age was around 47. Their UNOS status was from 1 to 4. Everything else was pretty standard as well. Their ischemic time was 183 minutes. Their comorbidities were also similar. And then also, when looking at their complication rate, none of these patients developed allograft rejection, and all the patients survived, with none of these patients developing COVID-19 infection during their index hospitalization. And again, nobody developing allograft dysfunction or rejection. One thing they did note in the article was that their biopsy schedule, they did weekly biopsies for the first month and then biweekly in the second month. And then after the second month, they transitioned over to non-invasive testing with AlloMap and AlloSure. And then they took all the standard precautions and screened patients with COVID-19 prior to performing all the biopsies. So in conclusion, this article reported 22 cases of COVID-19 in heart transplant patients with an overall 23% mortality. They noted that the outcomes were similar to the general population hospitalized with COVID-19. They also concluded that the heart transplant during the pandemic is feasible when appropriate precautions are taken with favorable short-term outcomes. But we need further studies to guide immunosuppression management in transplant patients affected by COVID-19. So I turn it over to the panel now for discussion.
Thank you, Miguel. So I would like to hear from Dr. McGillivray about the challenges we faced, especially during the surges, as we prepare probably for another surge right now. With the resource allocation in the hospital and also the challenges that they faced during organ retrieval.
Yeah, thanks, Ash. First of all, Miguel, great presentation of that, I would say, very reassuring study. Certainly in the beginning of the COVID epidemic, we were all very worried about what this terrible pandemic was going to do to our patients who had heart transplants, those patients who were awaiting heart transplant. And I think that, as Miguel pointed out, we've learned an awful lot in the last 9 months or so. And I think that all of the precautions that we've taken in general have been applied to transplant patients. Initially, our concern was trying to identify recipients and donors who might be asymptomatically infected with COVID. And I think that the access to rapid testing high fidelity rapid testing has really made a big difference for us. Some of the practical aspects of going out and getting donor, going to the donor hospitals, getting the recipients ready in the recipient hospitals, and keeping the staff safe. So, I mean, this is an unusual circumstance for us. Usually we're concerned about the safety and the survival of just the patients. This pandemic has added an extra layer of safety and survival for the staff. So certainly early on, we were very circumspect about sending our donor recovery teams to hospitals that were in areas that had high incidence of COVID. And just another practical nature of it, some of the states that we commonly would travel to would not allow donor teams from a high incident or high prevalence of COVID to come into those states or to those hospitals. So we would have to count on local transplant surgeons to assess and recover the donor organs for us, which was very different from what we usually do, and it was somewhat of a leap of faith. But that we've had very good experience with that. Have to take our hats off to the anesthesia team and the nursing team in the operating room, and all of the precautions that they certainly early on were taking that would potentially expose them to patients when we weren't able to test them early on. And I think that we have a much better system since we have the rapid tests coming back. So I think all in all, in our experience has been very very good.
I agree with you, Tom. I mean, we've probably now transplanted about 30 patients since March, or even more than that.
Yeah, I think more than that.
Yeah, and so far, we've had a good experience, and of course, we've had our challenges. And I'd like to hear from Dr. Bhimaraj about, at least a couple of patients who tested positive during the waiting period, and how to really determine the suitable transplantation period, in those patients.
Yeah, Ash, and Tom, I think you brought up a lot of good points in how we had to deal with it, and a lot of courage of individuals who took care of these patients in the front lines. Some of in our experience, we've had a few patients who were waiting and contracted the virus. So the question becomes on what is the timing for transplantation. Early on, unfortunately, we didn't know any better, and we had probably one person who continued to test positive, and to transplant somebody with an active COVID infection with multiple comorbidities is an issue because you suppress the immune system. Unfortunately, we did lose that individual. But as time went by with better testing and more understanding, I think the transplant community realized that some of the positives that persisted might not be indicative of a disease state. And I think then we identified based on other organs that we ended up transplanting as long as they've been a month from being positive. So I'm hoping this COVID thing will be behind us soon, but it's definitely challenged a lot of our conceptual frameworks.
Thank you, Arvind. So I think we'll go on to our next paper, again being presented by Dr. Castro, and this deals with pulmonary hypertension in pre-transplant patients.
All right, so the next paper is titled Predicted Heart Mass-Based Size Matching Among Recipients with Moderate Pulmonary Hypertension, Outcomes and Sex Effect. This was also published earlier this year, also from New York in Montefiore. So the background on this topic is, as we all know in the heart transplant world, severe and irreversible pulmonary hypertension is a contraindication to transplant. And the reason is because if we place a untrained heart in a patient that has high pressures, the heart will fail, cause RV failure. Now, moderate pulmonary hypertension also increases the risk of mortality, but this is not a prohibitive risk. We do transplant patients that have some degree of pulmonary hypertension. And historically, these patients that have moderate pulmonary hypertension would tend to receive oversized donors, despite there being really robust data guiding such a practice. This is mostly based on the theory that these patients will have a higher cardiac output, which would tolerate a higher afterload from this pulmonary hypertension. We do know that undersized donors have a risk factor for mortality, but again, studies have not conclusively demonstrated any benefit to oversizing these patients. And another thing that's to be noted is that previous publications, when looking at size mismatching, they use different metrics for size, including total body weight, height, and other parameters, despite different than what we use nowadays, which is predicted heart mass. So the objective of this study was to determine whether there's any benefit in oversizing donors as categorized by predicted heart mass in recipients with moderate pulmonary hypertension. And the primary outcome of this study was 90-day and 1-year mortality based on size matching. And then they also performed propensity matching to evaluate the effect of donor sex among male transplant recipients. So for the study design, this was a retrospective review of the UNOS database, and the inclusion criteria were pretty much transplant patients greater than 18 years of age with moderate pulmonary hypertension that were transplanted between 1994 and 2016. Exclusion criteria included patients that had any dual organs, retransplants, missing hemodynamic data, having extremes of weight, height, BMI, PA pressures, wedge, and cardiac output, and having differences in weight matching more than 100% or less than negative 75%. And they defined moderate pulmonary hypertension in two ways, either with TPG of 10 to 18 or PVR of 2.5 to 5 Wood units. And they did an analysis based on each of these, on TPG and PVR. And the definition of a heart mismatch was a 15% difference in predicted heart mass in either direction and considered as undersized or oversized respectively. Looking at the baseline demographics, so there was a lot of there were a lot of differences statistically in these the demographics, but it's due to the large sample size. But I'll point out some of the more important ones. So first, looking at the sex matching, as not surprising, the male donors to female recipients tended to be more oversized, and the female donor to male recipient tended to be undersized, as you can see here. Now, looking at the demographics for oversized patients that were important, the patients that received oversized donors tended to have a higher PRA. They had a shorter waitlist times. They also had a younger donor age and tended to have also shorter ischemic times. And looking at undersized patients, they tended to have higher BMIs, higher rates of diabetes, and their donor age tended to be a little bit higher. And looking at the rejection and death rates here at the bottom right, you can see that the unadjusted acute rejection the first year was higher in undersized patients, as well as their 90-day and 1-year mortality. Now looking at the results based on the PVR, as you can see here, they're based on undersizing by greater than 50% versus oversized or matched hearts. The 90-day mortality was higher in 90-day in patients that had high PVR and undersized at 10.6 versus 7.6 and versus 7.4%, as well as the 1-year mortality. And when adjusting for different variables with the Cox regression analysis, undersizing still remained with a higher mortality at 1 year, with an odds ratio of 1.2 and a p-value of 0.03. However, they did know that there was no benefit to oversizing the patients. We see here with a p-value of 0.9 when they compared it to matched controls. And when they looked at height and weight instead of predicted heart mass, there was no difference between oversizing and undersizing. When they looked at the results based on TPG, they found similar results with a higher 90-day and 1-year mortality in undersized patients. But when they looked at the regression analysis, they didn't find any difference between undersizing and oversizing when compared to matched controls. And at 90 days, undersizing and oversizing by predicted heart mass were not associated with mortality on multivariate analysis. And again, when looking at other size matching parameters, height and weight, it did not show any difference in mortality. And then finally, when looking at the effect of sex mismatch, they did propensity matching on 6,500 donors, and they were able to match 838 male and female donors respectively. And they found that the unadjusted 1-year mortality was higher for male recipients of female donors compared to male donors. But after propensity matching, there was no difference in mortality between male and female donors at 90 days. And when they looked at the female donor arm of the cohort, the 1-year mortality was similar for both matched and oversized donors. So in conclusion, in this study, oversizing using the predicted heart mass calculation was not associated with a reduction in 90-day and 1-year mortality compared to size-matched controls. Undersizing using predicted heart mass predicted higher day 90 and 1-year mortality, which is not surprising when taking PVR into account. And among male transplant recipients, matched female donors had a comparable 1-year mortality compared to male donors. And with that, I'll also again turn it over to the panel.
Thank you, Miguel. This is again a very interesting study and a very important conversation that we always have in our transplant board meetings, especially in patients who have moderate pulmonary hypertension. The questions are always whether we need to do an LVAD bridge, whether we need to check for reversibility, and also in terms of donor selection, how do we go about selecting an appropriate donor in these patients? And of course, as we prepare for transplantation, there is always a talk about at least appropriately sizing the donor. I'd like to hear from Dr. McGillivray what his thoughts are, and as a surgeon, what are the things that he would be most concerned about?
Yeah, thanks, Ash. I think that one of the things that, from a practical point of view, that almost never worry about oversizing, even pretty considerably much bigger donors. That's never really a problem, almost never a problem in smaller recipients, unless, of course, the recipient has some kind of restricted myopathy. It's encouraging to hear about the sex or gender findings of this study, although it is interesting that the unadjusted results show that female and to male donors had a higher mortality rate, but the propensity score matching did not. Unfortunately, when we're making the decisions, we don't get to propensity score match them prospectively. And so I wonder if there is some kind of selection bias that isn't really taken into consideration in the retrospective analysis. And the last thing I'd say is it's very encouraging to see the mortalities are not different, but just because you're not dead doesn't mean that you're doing well. So I know it's hard to do, but it'd be interesting to see what the functional status of these patients are at a year. I mean, if to see if there's any difference. But I would say that in large part these findings are very encouraging and does and should open up the donor pool.
No, I completely agree with you, and I think that's a very valid point about functional status, because we do see a lot of these patients that at 1 year that they may be more functionally limited, and we have often seen this. And of course, it also doesn't take into consideration other things such as a dialysis need or immediate post-operative RV dysfunction. Of course, these are also definitely considerations which I think we need to keep in mind. But like you said, I think appropriate matching is probably sufficient, and maybe oversizing is not really needed.
Not necessary.
Not necessary. Well, I think in the interest of time, we'll move on to the next paper, and Dr. Sunkara will talk about heart transplant in cardiac amyloidosis. And Dr. Sunkara, if you can share your slides as well.
Sure. Thank you, Dr. Guha. I'm going to share my screen now. So are you able to see my slides?
Yes.
Okay. So I'm going to talk about the next paper, which is a discussion about the outcomes in patients with cardiac amyloidosis undergoing heart transplantation. So this is a single center experience coming out of University of Stanford Medical Center. Just to give a brief background about this paper, so we all know in patients with cardiac amyloidosis, the mortality rate is high. And sometimes, and in those patients who go on to develop severe restrictive cardiomyopathy, sometimes heart transplant is the only therapeutic option. However, given the early reports showing poor outcomes in these patients, not all centers across the country pursue this option, and there are only few centers remaining, including ours, that do transplantation in cardiac amyloidosis patients. In this setting, I think it is important to record the experiences of the centers and learn from this, and so as to advance from in this field. So about this paper, this is a retrospective observational study. This study included all the patients who had a known diagnosis of cardiac amyloidosis that was confirmed with endomyocardial biopsy and underwent heart transplantation. So this was done during the period 2004 to 2017 and included a total of 31 patients, which included 13 AL amyloidosis and 18 ATTR amyloidosis. The authors go on to mention that the patients who had extra cardiac amyloidosis with clinical organ dysfunction were excluded from the study. So looking at the baseline characteristics, the patients with AL and ATTR amyloidosis were compared. In that comparison, we see that in patients with like ATTR cohort, they are older at the diagnosis, which is understandable, and they're more male compared to like in gender distribution. And they also looking at the other characteristics, they also tend to have like a worse baseline renal dysfunction, and they also have a longer wait times to transplantation. In others, looking at the AL amyloidosis, a majority of them are Mayo staging 3 and 4. And briefly, talking about the extra cardiac amyloidosis, the authors go on to mention that all the patients were screened for extra cardiac amyloidosis. However, they mentioned that the clinical dysfunction, such as, for example, GI dysfunction, GI motility, or malabsorption, such as those factors were factored into consideration for transplantation and just not the amyloid deposits present. And briefly to talk about the systemic therapy that they've done in patients who with AL amyloidosis who underwent transplantation. They mentioned that they have done autologous stem cells transplantation in a few patients, that is 5. And with the advent of the daratumumab-based regimen, they have stopped doing the autologous stem cell transplantation and continued most patients on the proteasome inhibitor and the daratumumab-based regimen. They also mentioned that they did not give any systemic therapy in a couple of patients who had like no like recognizable free serum free light chains post-transplant. Looking at the results, so these in this paper, the survival in these amyloid patients was compared to the survival of non-amyloid patients who underwent the transplantation in the same period. So looking at the survival, looking at this graph, you can see that the survival is similar in both the cohorts. The authors mentioned that the 4 people, there was 4 people died in the amyloid cohort died during the study period, and the causes of death were not attributable to the recurrence of amyloid, but were attributable to bacterial pneumonia, non-small cell lung cancer, and pancreatic cancer, and these developed almost like 5 and 8 years after transplant. And they also compared the outcomes between the AL and ATTR amyloid cohort, and looking at several features like post-op bleeding, post-op renal failure, or any infections or infections requiring readmission, or any episodes of rejection or malignancy were not like particularly different between the AL and ATTR amyloid cohort. Briefly talking about like the serum free light chain concentration in the AL amyloidosis patients who underwent transplantation. This graph shows the serum free light chain concentration in patients who received both either autologous stem cell transplantation or the daratumumab-based regimen. You can see that the daratumumab-based regimen had achieved consistent lowering of the serum free light chains, and after the autologous stem cell transplantation, there was also greater degree of reduction in the stem cell free light chains, which I think begets the question, is there still a role of stem cell transplantation in these patients post-heart transplantation? So in conclusion, heart transplantation in carefully selected cardiac amyloidosis patients is safe and effective, and this results from the study are similar to our experiences from our center and also other centers such as Mayo Clinic. I now turn the discussion to the panel. Thank you.
Thank you, Anusha. Like you said, again, these are a very difficult population to transplant, and we are indeed fortunate to be in a center where we've built a very good amyloid program and hence an amyloid transplant program. I'd like to hear from Dr. Trachtenberg about our experience here, and also he could share some of his findings from his paper that he's recently published as well.
Yeah, thank you. Great presentation. So I think the important take homes from this study are two things. One, this is another study along with our paper, along with the paper from the Heidelberg group in Germany, that shows that amyloid patients can do very well post-transplant with survival. Both the Heidelberg group, they divided into two eras and showed that their 5-year survival was about 75%. We published our AL amyloid experience in patients that had stem cell transplant 1 year post heart transplant, and found we also had excess of 75% 5-year survival as well. So this is just another data point that shows emerging evidence that carefully selected amyloid patients can have good outcomes, and we should not exclude them from advanced heart failure therapy. So I think it's really important to note that. I think what's interesting about the Stanford approach is that they did abandon routine stem cell transplant. I think they're one of the first programs to do that. With new therapies, proteasome inhibitors and daratumumab, there's a question of whether there's a role for stem cell transplant. Certainly in AL amyloid in general, there's been one randomized trial that was with older chemotherapy, and it had worse outcomes compared to stem cell transplant. There is some evidence that you might have a longer remission period with stem cell transplant, but we don't know if that holds true with current therapies. So that's a big question mark. I think we don't know the answer, but either way, it's encouraging that patients with amyloid can undergo transplant safely. They have chemotherapy that can help keep them in remission, and sometimes you can do a stem cell transplant as well. When I was in fellowship, we sent patients home for hospice, and so it's great that we have more data showing that we have outcomes that are at least equivalent to non-amyloid patients, with the caveat that these are carefully selected patients. These aren't all comers with amyloid.
Thank you, Barry. Just as a reminder to our audience that you can text your questions to text DEBAKEY to 37607, or you could go to pollev.com and enter DEBAKEY. And this way you can ask us some questions. We have a couple of questions coming in. Tom, this one's for you in terms of how successful are LVADs in amyloidosis?
Yeah, it's a great question. I think that the results have been somewhat mixed across the country, just because amyloid patients oftentimes have a restrictive component to it, and their LV size, chamber size, is not very amenable to intracorporeal LVAD. We have had success. Other centers have had success, but I think it's on a patient-by-patient basis.
Thank you. And Barry, this question's for you. Is there an outcome difference between transplanting AL versus TTR amyloid?
So I don't think, it's a great question. I don't think we have enough data to show that. I mean, I think we have non-published data with our TTR with very good outcomes. I know just from personal communication with Cleveland Clinic, they do as well, and some other programs. So I think there's, I suspect TTR outcomes might be better, but we don't really have evidence to prove that. And certainly with the Stanford data, with the German data, with our data, AL amyloid patients can do very well. But, again, these are not all AL amyloid patients, whereas TTR were probably not as selective as long as they're within the age limits.
And one of the things, in the Stanford study was that they did not have much change in post-transplant immunosuppression. What are your thoughts on more tailoring of post-transplant immunosuppression, especially in AL amyloid patients in the setting of daratumumab?
Yeah, so that's a great question. I mean, I think In terms of our data, pre-daratumumab, our rejection burden was actually pretty comparable to our non-amyloid patients. So this is small numbers, so it's hard to know for sure. With daratumumab, we have had a couple patients now that have had daratumumab and then had transplant. And we do see a lot of hypogammaglobulinemia in these patients. So we've certainly had less patients on CellCept post transplant if they've had daratumumab. So I suspect the infection rate, once we see more data with Dara, will be higher if we don't tailor the immunosuppression down a little bit.
Thank you very much. And then we'll move on to the next study.
No, I'm going to share my screen. Okay, so the next paper is going to talk about different immunosuppression regimens after heart transplantation. It's a propensity score matched cohort analysis by Lee et al. A little bit of background about the study. We have the standard immunosuppression regimen as steroids, calcineurin inhibitors, and mycophenolate meftal. Studies have shown that sirolimus and everolimus, which are the mTOR inhibitors, have a beneficial effect on cardiac allograft vasculopathy, renal function, and graft rejection. And they've been shown that conversion from a calcineurin inhibitor to mTOR is safe. However, we lack data in patients with prior episodes of rejection or high sensitization. And we also don't have any data about evolution of DSAs with everolimus. So this study aims to address those issues. So as I mentioned, the objective of the study is to compare the standard immunotherapy regimen to a quadritherapy maintenance regimen, which includes the addition of low-dose everolimus in addition to the standard immunotherapy regimen. This is a single-center observational retrospective study conducted between the periods 2014 to 2016. All the patients more than 18 years of age who underwent transplant between 2014-2016 and who survived the 3-month period were included in the study. Patients who had a redo transplant or a multi-organ transplant or renal failure requiring dialysis post-transplant, and a patient who could not receive standard immunotherapy regimen, immunosuppressive regimen, were excluded from the study. So briefly talking about the immunosuppressive regimen, every patient in standard immunotherapy suppression regimen consisted of induction with ATG and high-dose steroids. All the patients who had preformed DSAs underwent plasmapheresis, and the regimen in the initial 3 months consisted of tapering dose of steroids and the calcineurin inhibitors, which were started on day 2, cyclosporin and tacrolimus, and the mycophenolate meftal started on day 4. And the patients who, in the selected patients who were selected into the study, the everolimus was added starting 3 months after transplant, and it was delayed in case of any active rejections. And the dose was 0.25 milligrams twice daily with a target trough of 3 to 5 nanograms per ml. And the calcineurin trough targets were lower when the everolimus was added. And the outcomes that were assessed were mortality between the two, compared between the two groups, any biopsy-proven acute rejection, which is again compared between the both groups, evolution of donor-specific antibodies, and the cardiac allograft vasculopathy. So the statistical analysis is a little complicated in this paper. All the patients were included in an intention treat analysis. However, they also created 2 propensity matched cohorts in order to help address the selection bias inherent to this kind of retrospective studies. They also did a multivariable Cox analysis on all the cohort of the patients, and also an inverse probability score weighting on all the patients. So this is the study that was organization of the study. 283 patients were underwent transplant within the period, of which 70 were excluded for different reasons. 213 were included, which 75 of which underwent the quadritherapy and 128 of which underwent the tritherapy. In these 2 groups, again, with the propensity matching, they created a matched cohorts consisting of 64 patients each. But the analysis was conducted in all the patients as well as these matched cohorts too. Baseline characteristics, this is a busy slide, but like the baseline characteristics were comparable between the both groups, except for like cumulative donor-suppressive donor-specific antibodies, which were slightly higher in the tri-therapy group compared to the quadri-therapy group. Going to the results, as we discussed, they assessed the all-cause mortality between the both groups. Here in the graph, lines in the blue represent the tri-therapy, and the lines in the red represent quadri-therapy, and the dotted lines represent the overall cohort, and the solid lines represent the matched cohorts. And they projected a significant difference in all-cause mortality between the quadri-therapy and tri-therapy, with quadri-therapy being better projected. And looking at the survival without rejection, so survival without rejection was again higher in the quadri-therapy group compared to the tri-therapy group in both overall cohort and the matched cohorts. Looking at the evolution of de novo donor-specific antibodies, there was no significant difference between the evolution of donor-specific antibodies in the both tri-therapy and the quadri-therapy group. They compared with the match cohort, but looking at the paper, even in the overall cohort, there was no significant difference. In even the renal function, there was no significant difference between both the groups, both in matched cohort, and if you look at the paper, just in like the overall survival too. In cardiac allograft vasculopathy, there appeared to be a significant difference between the quadri-therapy and the tri-therapy group in the matched cohort, which is seen in this table. But however, in the overall cohort, there appeared to be no significant difference. So they call it as like the quadri-therapy group did not have a significant benefit in the cardiac allograft vasculopathy. Coming to the safety of the everolimus, 75 patients in the quadri-therapy group required treatment discontinuation, and there were a variety of reasons requiring the treatment discontinuation, which included venous thrombosis and the mucocutaneous manifestations, and some others such as hepatitis, muscular dystrophy, dyslipidemia, colitis, and non-specific symptoms. And mortality in patients who withdrew from the EVL was similar to those who did not. So with that, I turn the discussion to the panel. Thank you.
Again, a very interesting study. In the last 2-3 years, there have been at least 4 studies now with looking at mTOR inhibitor use in heart transplantation, and all of them, have shown very significant impact on cardiac allograft vasculopathy, but definitely on survival as well. So I'd like to get your thoughts, Dr. Bhimaraj, on whether mTOR inhibitors are now, going to become a standard of, care in immunosuppression in heart transplant.
Yeah, Ash, I think this is a very nice study to acknowledge that mechanistically, when we treat transplant patients, we're so focused on the T cells and rejection that we're forgetting the alternative mechanisms that includes the endothelial cells and things which are beyond T cells. And we've always struggled to use mTOR inhibitors early on because of individuals getting higher rates of rejection, and that's been established. I think as having a strategy of tempering with a little bit of a CNI along with the mTOR inhibitors makes perfect sense. I think it's definitely reasonable to revisit it, and as you know, in our center, we have been more proactive in using mTOR inhibitors, but not necessarily in the first year. But this opens up some discussion on trying to overlap it, especially in individuals who are at lower risk of rejection. The other problem is the tolerability, and as you noticed in this, we see that, and there's no easy predictive ability, but 1 in 4, right, 25% of them can't handle it. And you go through the whole drill of trying it and essentially leg swellings, edema, and then you discontinue it. So the tolerability improves, I think mechanistically, I can see some kind of a strategy where you will make mTOR inhibition a part of your regimen, a standard regimen for treatment, definitely.
And the initial studies really focused on CAV prevention. So almost every, that led to the practice of needing IVUS and using IVUS to decide whether to switch somebody to mTOR inhibitors or not. Now we are seeing all these studies where they're being used more just upfront as standard of care. Do you think there is any role for IVUS anymore in heart transplant recipients, or should we just be switching people to, or adding mTOR inhibitors without needing IVUS?
No, that's a valid point. In fact, I remember in my training, our center was in Cleveland. We used to do IVUS in every patient, at the end of the year. And if you think about it, that was the discussion saying, why are we doing this? Because IVUS was an endpoint in trials, and it's the delta change, which is a minuscule outcome. And if you want to prevent it, you might as well try it very early in individuals, whoever can tolerate it. So that's why I think IVUS prevalence as a routine clinical care is not that rampant in many centers. I do think there's a role to identify the benefit of mTOR inhibitors and use it in individuals, whether your IVUS shows a change or not, as early as you can. As I said, the limitations are the fact that you have rejection and tolerance, and if you can overcome that, I think using it very early is probably a best strategy.
All right, very good. Thank you everyone for joining, but I'll let Dr. Bhimaraj end with some closing remarks.
Oh, thank you, Ash, and I think the intent of this heart failure hour that we've started every month on CV DEBAKEY Live is really identify the fact that heart failure is such a broad field, starting from early heart failure to advanced therapies like VADs and transplants. And thank you for picking this topic on transplant, because it's a vast area and very complex science that sometimes gets not appreciated in the world when we talk about heart failure and talk about things ranging from immunology to infection to outcomes. So the concept to scan the journals and present it to our audience and us is I think is a very good idea, and I hope we can continue this. And we all acknowledge the topics we talked about today, dealing with COVID in transplant to amyloid to different immunosuppression. I think that variety in transplant is really an exciting field from scientific standpoint. And we're very lucky to be in an institution where we embark on the strengths of the DEBAKEY Heart and Vascular Center on one side, and then the J.C. Walter Jr. Transplant Center on the other side, where we get the collaboration from all different organ transplants to be able to learn about immunology, do the dual organ transplants. So I think we're very thankful for the DEBAKEY Heart and Vascular Center. We're thankful to the Transplant Center and all the support that we get. As all of us acknowledge, it takes a country really to run a machine like this and take care of their patients, their needs, their social needs. So again, thank you. I thank all the audience today to have listened to this and identified the topic. I want to thank our both fellows to have taken the time, and of course I want to thank Dr. McGilvory, not just to be on the panel today, but all the nights that he spends harvesting the organs and making these tough decisions. But thank you, Ash. Thank you, everybody, and have a good evening.
Good night, everyone.
Night.